Happy Sunday, everybody. It's good to see you right here on Health Diary. My name is Winnie Lubembe, and we're coming to you from the Aga Khan Hospital right here in Nairobi. So last week, we started a conversation on breast cancer screening, October being Breast Cancer Awareness Month, and we focused on mammogram. But today on the show, we'll be focusing on ultrasound and biopsy. So what exactly are they? Who qualifies for an ultrasound or not? Well, let's find out after these facts of the matter.
Breast ultrasound is an imaging tool used to detect and diagnose breast cancer by distinguishing between fluid-filled cysts and solid masses. But it is not a definitive diagnostic tool on its own. It's most valuable for women with dense breast tissue or when following up on a lump found during a mammogram.
All right, let's get to understand ultrasound for breast cancer screening. And to help us with a conversation, we still have Dr. Rose Ndumia, who is a consultant breast radiologist right here at Aga Khan Hospital. Dr. Thank you so much. Good to see you again.
Good to see you.
So before we talk about ultrasound, right, there's a lot of conversation about the reason why more and more women are actually getting breast cancer. And there was also a conversation about younger women. We're seeing a lot more of that. Can we just, first of all, get to understand that probably what has brought up to the surge in the number of women and also when it comes to the age as well?
Yeah, I think it's twofold. One way I see it is as we've raised more awareness about breast cancer and screening, more people have come up. And as you screen more people, you're going to pick more cancers. So we end up having this, picture where we're seeing there's more and more breast cancer that we're picking up. Is it that there's been a surge of the breast cancer? But it's actually, as more people are aware, more people screen, then you pick up more of the disease. The second thing I think might be because of lifestyle changes. When you compare our breast cancer incidence, it's nowhere close to like in the developed world, and so as we acquire more and more lifestyle traces that mirror the Western world, and those have an influence in terms of the risk factors for us getting into for more women to develop breast cancer. So it's a gradual rise also that we've been seeing over the years. But I think it's those two. As we modify lifestyle and becomes more westernized, then we start getting increased incidences, just like there is in the Western world. And as we screen more people, we'll pick up more disease. And then we become more aware. And I think the media is doing a good job in raising their awareness.
And also on the population when it comes to the age, we're seeing more younger women getting breast cancer. Do we know why? Is it still on the lifestyle, the trends?
So it's very saddening, but I've seen this also on a global level. I wouldn't say it's something unique to just Kenya. Like where I trained in a Middle Eastern country, and I'd see breast cancers even at 24, 26. And equally, I've seen breast cancer here in ladies in their 20s, 27, 26, which is very sad. At that age, you should be thinking about other things, about, dealing with such a difficult diagnosis. So there is early breast cancer that we pick in those younger ages. So normally when we diagnose breast cancer at this young age, what we'll recommend to such patients is for them to get genetic testing. And most of these patients, you'll find there's probably a genetic mutation that then predisposes them to the breast cancer, and then it manifests earlier. So it's something it's a trend that you see even in other countries, but also happening in our country.
One would then ask, and especially the peak around the 70s.
Yes.
Is there something that maybe can be done to prevent that?
It's very hard to tell, right? It's really hard to tell. So there are risk factors that we know about. Some you can modify, some you can't. And so like things like obesity, that's something that you can modify. The age at which whether you get children or the age at which you get them, that you could argue is something you cannot really predict or influence someone to do. And things like smoking or alcohol intake, those are things that someone can control for throughout their ages. But in terms of controlling those that come later on in the years, it's really hard to control. And that's why the screening is important, because we can't tell who's going to develop the cancer. But if at all we can screen and pick them early, the better. So one of the things we advocate for is that if you have a first degree relative, so either your sister, your mother, or grandmother who had breast cancer, at whichever age they had their breast cancer, make sure you've started your screening like 10 years earlier.
Okay.
So let's say you had your mother get breast cancer at 48. And here we are saying that we start screening from 40. But in your case, you'd want to start actually from 38.
38.
Yeah.
I think that goes to say how important it is to ask questions, because for most of the time in our families, we don't ask questions in terms of like grandma, mom, is there a history and whatnot? Because if you're saying that helps during the screening process, then you need to ask.
We need to ask,
right?
We need to ask. The challenge I've seen is sometimes, especially grandparents, sometimes we never get to know what happened. And I think now as we get, people are more knowledgeable, more engaging, living longer, it's very easy now to ask those questions. What happened to so-and-so? What really, so then you're more aware. The challenge comes also again if there are people who are a bit private. So I may not want everyone to know what I had. Like the way with HIV, there would be a bit of stigma. So equally, I don't think having a cancer diagnosis is something that's completely free of stigma. There are those ones who would want to keep it to themselves, not share it too much within the family circle. So but I think it would be a strong point if that person can be the advocate for the family members. So like I'll give you an example. If a man is diagnosed with breast cancer, then that's someone who I would want all the women, children he has hired should come for testing. Probably his own sisters, he should be advocating them to come for screening. Because by the time a man is getting breast cancer, you also wondering, where did it come from? Maybe there's a genetic component. So actually, and it has worked where you've seen, because one person has been diagnosed with breast cancer, you find now the next week or two, the relatives are coming in and doing their screening. So I usually find a lot of breast cancer warriors are usually the advocates, even within their family circles, their friendships, social circles, who advocate for mammograms.
And speaking of screening, so we did an episode on mammogram. Ian got so many useful insights on mammogram. But now today we want to focus on ultrasound, right? And just get to understand what that is like, because most of the time when we think about ultrasound, we think pregnancy, right? Exactly. So can we just get to understand the basics about ultrasound, what, it looks like goes ultrasound versus, who doesn't qualify.
Wonderful. So as I mentioned last time, to do with the mammograms, they emit low dose X-ray, which is ionizing radiation. And as I took you back to the physics class, allow me to do that as well. Okay. So this is an ultrasound machine, and these are probes that we use for different applications. So within this ultrasound probe, the way it's built, it emits what are called ultrasound waves. So ultrasound waves are still part of that electromagnetic spectrum that we talked about, but ultrasound is safe. It doesn't emit radiation. So with those ultrasound waves, you're able, because of as the ultrasound waves are emitted, depending on the structure that they encounter, they bounce back into the transducer, the probe or the transducer. So this bounces back depending on how dense or how stiff a structure was, then it creates the image for you. Well, who gets to do a breast ultrasound? So let's say a woman is under 40, she's average risk and just wants to have a checkup or to be screened. So she's not yet 14, meaning she's not at the age of doing screening mammography. Then she can do the ultrasound. Now, we have another group, which we had mentioned before. When you do a mammogram, we could see dense breasts, and we're not sure if maybe there's a small lump that's been obscured. So women with dense breasts will require the breast ultrasound to be able to rule out if there are any small masses that were obscured by the dense parenchyma on the mammogram. The other group are patients, they did the mammogram, and then there was a lump that was seen. And we want to see, is that lump a cyst, in which case it's completely benign, you don't need anything additional, or is it a mass? And when you see this mass, ultrasound is very good in characterizing that lump, because not every lump also needs to be biopsied. So depending on the morphological characteristics that we see, how we assess it using the ultrasound, we can then tell that this is a mass that needs biopsy. And then this is a mass that needs to be followed up closely so that you see whether it's going to remain stable or it's going to get larger or develop abnormal characteristics. Then deem it necessary to do a biopsy.
Okay.
Yeah.
Are you able to say from your
Yeah.
where you sit, even just looking with the ultrasound or even mammography,
Yeah.
are you able to tell whether this is cancerous?
Yeah. So so when we do the ultrasound imaging and also when you do the mammogram, there's something called BIRADS that we assign, a category that you see in your report at the conclusion section. And the BIRADS just stands for Breast Imaging Reporting and Data System. It's a standardized system of reporting worldwide, such that if you took your report from here in Kenya, went to Australia or to the US, they would understand that language, yeah? And it creates uniformity such that even when you take it to a breast surgeon, they would know exactly what needs to be done for this patient. So when you come and you do the ultrasound and I see a mass and maybe it's irregular, it has speculated margins, it has calcifications, it's very stiff, even the skin is being pulled back or even the nipple has been pulled back, that one is a mass that's very highly suggestive of malignancy. So those are the ones you see us giving category 5, BIRADS 5. It's highly suggestive of malignancy. And actually these BIRADS categories are telling you the likelihood of this lump being malignant. So if I said like from BIRADS 5, it's more than 95% chance that this is going to be a cancer. When it comes to BIRADS 4, now we're seeing a lump, it's irregular, microlobulated margins. It doesn't tick all the boxes, but it has even at least just one suspicious feature is enough for me to give you BIRADS 4. So this has a wide range. So it's from a 2% to a 95%. So if this mass has 2% to 95% features of malignancy, then it's a BIRADS 4.
All right.
So you see, it's a wide range. Yeah. So we usually break it down to 4A, 4B, 4C. So that it's in, understandable formats. So like 2 to 10% will be 4A, 10 to 50 will be 4B, and then 50 to 95 will be 4C. So you have those subcategories within the 4. And then BIRADS 3 is where we see a nice oval circumscribed mass, doesn't have worrisome features, and this has less than 2% chance of being malignant. So you really don't have to go and biopsy them. And so these are the ones we follow up in 6 months, and then 1 year. If they're stable for 2 years, then you deem them benign. However, in the course of those 6 and 1 year follow-up, 6 months and 1 year follow-up, and you find the mass has become bigger by more than 20%, or it's developed a suspicious characteristic like a speculated margin, then now you have to biopsy it. Now you upgrade it. Yeah. But if it's stable for 2 years, you downgrade it from a BIRADS 3 to a BIRADS 2, which is benign. And then when you don't find anything abnormal, it's BIRADS 1, negative. Yeah.
Interesting. And thinking about biopsy, from when we come back from the break after we see, how the whole process works, we might also want to touch on a little bit about biopsy. What does that look like? Who goes on therapy and whatnot? Well, all that is coming up after the break. Just stay with us. The show is Health Diary. Welcome back to the show. And today we're looking at ultrasound for breast cancer screening. And we still have Dr. Rose Dume, who's a consultant breast radiologist right here at Aga Khan. And Akona Nani.
Jane Gakodio.
Yeah. To say it, yes, sister close. No. Jane just started to take through the entire process, and so we see what exactly happens during, the ultrasound. Doc, you were talking about what the ultrasound machine looks like, and then we can see our dummy. He's already here. Jane is ready with the placement. Yeah,
exactly.
Yeah. So ideally, what usually happens? What is that whole process like?
So first of all, we'll get the patient to come in, explain why they're doing this procedure. They'll get into the changing room. So it's really good if patients, when they come in for both the mammogram and ultrasounds, they can wear a 2-piece outfit. It makes it easier to dress up and, undress for the procedure. Then we'll place them on the couch, as you've seen, and they'll usually be tilted slightly because the breast is a bit mobile and want it uniform thickness. So once that's done, we apply gel. So this is water-based gel that just helps to remove air. Okay. So one thing with ultrasound beams, they don't traverse well through air. And so you need the gel to create a airtight contact between your probe and the skin surface. So once that's established, then now we acquire an image. So in this case, you can see the skin, we see the fat underneath the skin, and then the white is the glandular tissue, the fibroglandular tissue. Remember, it was white on the mammogram. It's also white on ultrasound. But when it comes now to the lumps on the ultrasound, they're going to be black. So it's very easy to pick the black lumps in this white background. So like coming now in view here, we can see this is an irregular mass. It has these spiculated margins. It's heterogeneous. So in this particular case, this is a suspicious mass. This a Barrett's 4 mass, and this is a mass that would require biopsy. So another opportunity that we have when we are doing breast ultrasound is also to assess the armpit. So within the armpit, there are what are called lymph nodes. And this sometimes are not captured very well on the mammogram because they could be deep in the armpit. So when you're doing a breast ultrasound, you have an opportunity to scan the armpit and check, because when someone has breast cancer, the first place the breast cancer will spread to is the lymph nodes in the armpit. And so you want to establish if they are normal or not. If they are abnormal, when you do the biopsy, you will have to biopsy both the lump and the lymph node. And that will be very useful information to the oncologist in the decision-making process, and also the surgeons in terms of which therapy do we start with. Do we start with surgery? Do we start with chemotherapy? Does this patient need a full mastectomy? Will they need a clearance of their armpit? So all this information is something that we are factoring in as we think of, if this was a cancer, what are the steps down the line? And this information will be useful for.
Remember during the mammogram conversation, we were talking about breast density.
Exactly.
So I'm just curious if is also a factor when it comes to like an ultrasound.
Yes. So the density of mammography doesn't impact the ultrasound because, as I've shown, the fibroglandular tissue, this white tissue, whereas on a mammogram, the lumps would be white and therefore harder to see. Here, the lumps are dark. Yeah, so they really stand out very easily for you to see. So the density doesn't affect us. Actually, what might affect us is if someone is really fatty and you see more of the black tissues and you're looking for the black lump, that might be a challenge, especially if they are small. So that might be a challenge. But the other thing that might be a challenge with ultrasound is because it's very user dependent. So depending on where Jane places her probe is what we see on the image. So just by missing 1 centimeter, you could miss a mass there. And that's why it's very important to start off with a mammogram first. It creates like a roadmap for you, even for Jane when she's scanning the patient. She really has the mammographic findings to guide her where to exactly to check. If you were to start with an ultrasound, you could skip something. Then you go do a mammogram and you find, there are lumps there that you didn't. Then the patient has to reschedule again to come for a repeat ultrasound. So it's a very disjointed consultation if you go that route. So we really advocate for women from 40 onwards, start off with your mammogram, then do the ultrasound. It will give you a more seamless experience, and instead of the back and forth, you start with the ultrasound.
I see that. And then during the self-breast examination, we're always told sort of like divide the
breast
into 4, right? So I wonder if that is the case for an ultrasound as well. Is there like a part?
Definitely. So we divide the breast into quadrants or quarters. And actually, even like when we're creating the reports, we want to, describe the mass, give the measurements, and say the location they're in. So when you read your report, you might hear there's a mass in the upper inner quadrant. So like where she is right now is in the upper and inner, using the nipple as the reference point. So anything above the level of the nipple, that's upper, and then below is lower. And then you look at the nipple and you're going more inner or outer. So those will be the quadrants. We also use the clock position. So you look at the breast like the clock face. So this will be like 12, that's 3, 6, and 9 o'clock. And again, you tell where the mass is. Then you have to say how far from the nipple the mass is located. so that it's easy. Like even when I'm doing my mammogram report, I'll say, I see a 1 centimeter mass in the upper inner quadrant located 10 centimeters from the nipple. So when Jane is scanning, she really knows it's not something I'm looking for here.
Yeah.
10 centimeters will be like quite far away.
Yeah.
It's easier for her to find it.
Okay.
Yeah.
Interesting.
Yeah.
And then I guess, so how long ideally does it take? Because for mammogram, we said 8 minutes thereabout and you're done. So for the ultrasound?
So when you're doing a bilateral breast ultrasound, you actually get a 40-minute slot. So it's much longer than the mammogram because as you see, we have to go combing through every area in the breast, both breasts and the armpits. So for both breasts, we give you an appointment time of 40 minutes. You may finish earlier if there are no findings, but there are times you find multiple findings that you have to get, a detailed focus view. If at all, maybe is in the process of the sonographer scanning the patient, they need some assistance. That time is also factored in. We would come in and we look at the images together, scan the patient together so that she leaves here fully assessed.
Yeah.
Men
Do they
also do this. Yes. So as I mentioned earlier, the men who can get gynecomastia and also others may have breast cancer. To differentiate the two, you need imaging. So in addition to the mammogram, they also do the ultrasound. Yeah. And so the ultrasound, they go through the same process.
Yeah. And also ultrasound can be used for diagnosis as well.
So all this, when we talk about like the diagnostic workup, it's the mammogram and the ultrasound. It's helping us arrive at that BI-RADS. So when you do the mammogram, you saw a mass, you couldn't tell whether it's solid or cystic, you give it a BI-RADS 0. And then now you came for your ultrasound, it showed this irregular looking mass. We give it BI-RADS 4 or 5. And from there, we guide you to do a biopsy.
Yeah.
So when we do the biopsy, we do it under local anesthetic and image guidance. We're not doing blindly. We're using the ultrasound to show us where the mass is, give local anesthesia, and then using a needle, a core needle, we go and take samples from the lung. Now, those samples are placed in a special solution called formalin to preserve the cells, and they're sent to the histopathology, a section of the lab. And now the pathologist is the one who will interpret the tissues and give us the diagnosis of whether this is a benign lump or if it's a malignant lump and which type of malignancy, whether it's hormone positive or not, the HER2 status, how fast it's replicating. All those details will come from the pathologist's report.
Interesting. Yeah, when she's doing that, I'm looking at, when you look at the breast just like that, you don't see nothing.
Yeah.
And then you see this, and I'm like, that is ginormous.
Yeah. So oftentimes when it's just kind of patients, they'll tell you, oh my God, that looks very big on the screen. But you see, we also zoom in on like the image magnifiers so that it's easy for us to see what we are scanning.
Okay.
Yeah. So here it might look bigger than actually the way it is. It's just for us to have finer details to be able to characterize it and give the correct diagnosis.
Interesting.
Yeah.
Okay. And then how often do people go for
ultrasound? Ultrasound has no limitation to when you do it because it's not emitting radiation, but usually would pair it up together with the mammogram for those who have dense breasts. And for those who are under 40 and just want a checkup, they can just do it annually. Yeah, but it's not something, like if you develop symptoms and you're not yet at the time when you should do your mammogram, then the ultrasound is what you'd go for.
Yeah. Is there things that people need to know when probably preparing for an ultrasound? I know for mammogram, so we said, do not apply deodorant, or if you do, you'll have to wipe it
You'll have to wipe it down. So for the mammograms, the preparation is wear a two-piece outfit, preferably. Avoid applying lotion and deodorants because those can affect the image quality. Otherwise, you'll have to wipe it down when you're coming for the procedure. For the ultrasound, the main thing is just wearing a two-piece outfit so it's easy to change, but there isn't any limitation in terms of deodorants and lotions. And whatnot.
All right. And I feel our time is far much spent and we have to say goodbye. But you touched a little bit on the biopsy, right? So anything else that we need to know on biopsy? Does it accompany, say, mammogram and ultrasound? Yeah.
I would say one thing that's very important for patients to be aware of a biopsy, and I like using this analogy, is if you had, let's say, a tummy ache, and you went to the doctor, they'll probably send you to the lab to do some blood tests, maybe check your urine or check the stool. When it comes to a lump, what you need is tissue from that lump. That's the only way you can be able to tell what's going on here. And that's now what we call a biopsy. We usually do it under local anesthetic because a lot of patients are concerned, is it going to be painful? They come, they're very anxious, apprehensive, and the number one question, is it painful? So it's not a painful procedure because we do it under local anesthetic. Now, you can do your biopsies under ultrasound guidance, like the machine that we have here. But sometimes there are findings that you only see on a mammogram. In those instances, then we would have to do a mammographic guided biopsy, which is also called a stereotactic guided biopsy, which is much more uncomfortable because the breast is still compressed for that entire duration of the biopsy. So that would be like for suspicious calcifications and you can't see a mass on ultrasound. So that would do stereotactic biopsy, but they're less frequent.
So thank you so much, Jean. Really, yeah, I'm like, oh my gosh, okay. This is what happens. Doc, even as we bring this to a close, just to speak on the cost aspect of it. And during this breast cancer awareness, we also have that subsidized and they're covered by insurance.
Yeah, so breast ultrasound is usually a little more costly. Actually, let's say double the cost of the mammogram. And as you can see, you're spending more time doing it. It's more time consuming. And so we charge it more. But you also enjoy the same discount when you come in October and you come in February. Yeah, and it's not everybody who will end up requiring it. But if you do require it, you'll be informed through your report, or even your doctor will have sent you for both a mammogram and ultrasound.
Yeah, I see that. Thank you so much, Doc. And thank you so much as well for allowing us into your space, despite the busy schedule. That has been Dr. Rose Ndumia, who is a consultant breast radiologist right here at Aga Khan Hospital. Well, time now for you to take a look at this health tip.
Today's health tip, we're going to be focusing on screening and early detection of breast cancer. So for the first tip, don't wait for a breast lump. Come for screening, in which case we'll be able to pick up lumps even before you can feel them. So remember, don't wait for a lump.
Well, we've come to the end of our conversation today on understanding ultrasound as well as biopsy. Now, we hope that we have helped to clear some of the myths and misconceptions that probably you had as far as ultrasound is concerned. And yes, both men and women can go for an ultrasound. It is safe. So take advantage of the October being Breast Cancer Awareness Month and probably gift yourself. Go for a checkup and understand where you are at as far as your breast health is concerned. Well, if you have any other question, our social media handles are down at the bottom of your screen. My name is Winnie Lubembe. Special thanks to the Aga Khan Hospital right here in Nairobi for hosting us today. Until next Sunday, adios.